that if you start doing Poncetti or you don't have enough experience and start trying to do arthrogryposis, myelo, or relapses after surgery is very hard. You need to know, you have to have a lot of experience in idiopathic before you can jump into those cases. Otherwise, it might not work for you, and you might not get these results. Now, I think this is very important conceptually, and this is what I wanted to present in this presentation. Just a reflection. You have kids that are born with a deformity like this, and what you want is to obtain a foot that is nice and flexible, with no contractures and with no pain. And you have two choices. And I think this is important to think about this. You have your knowledge in your head, and then you have your hand, and then you have a different instrument. You have a knife here, or you have the plaster cast. And I think this is very, very important for you to consider this, because what happened is that most people, or a lot of people, think that because you use something that is messy, it's something that is not powerful with respect to correction, and is left to the physical therapist or the nurse or the junior resident or somebody low in the totem of the clinic. And I will argue that deformity is the same no matter what instrument do you use, this one or that one. And getting a good correction requires the same precision, because the ligaments and tendons are the same, and you have to treat them the same. Now, if you decide to go through this route, you will never agree not to do it in an environment like this, okay? And you will need a team like that. Otherwise, it's like, I'm not doing this. And you don't do the surgery with 3 kids in the same room. You just do it one at a time. But if you use this, you do it in the classroom, there's another 5 people over there, there's a lot of noise, the kid is completely like crazy if you do it that way, and then it's very difficult to get the correction because the muscles tied up and so forth. So unless you use the same concepts of correction when you use this instrument, you are not going to get the same results. And that's the reason why many people get okay corrections, but not 100% corrections. So you need to learn also how to use your instrument. And your instrument is your hands with plaster cast. And this is what we were talking about, how you put your thumb in the head of the talus. You see, Dr. Poncetti is touching with this part of the thumb, not with this part of the thumb, because if you touch with this part of the thumb, you are blocking the calcaneus underneath, because it's very close. Okay? And then you have to elevate the first metatarsal and then bring the foot in abduction. And you have to do a cast that is extremely molded, because that's the way to get the foot to change the shape and to stretch. And if you do it this way, with 5 casts, 95% of the time in idiopathic clubfoot, you can get correction. In arthrogryposis and myelo, is 6 or 7 casts, so 2 more, although they are very rigid. So your casting technique is critical for the results of the Poncetti method. It's not the foot that is more rigid, this one is not working. So these are not, and this is from John, I think. These are not Poncetti casts. There's no, I mean, like this one. And Monica has, shown some of these cases. I'm doing Poncetti, okay? I mean, it's like, it's just the name that you're using, but it's really not the method. And there's a lot of, kind of chatter in the internet and also in the, in the orthopedics. Oh, I use soft cast, I use fiberglass. I mean, just think about yourself. What is the material that you have in your clinic that has the most molding capability? Regular cast. I mean, it's like you have regular cast that is the best material to obtain molding. Why do you want to be using something that doesn't get enough molding? I mean, just think about yourself. Because it's cool, because it's, it's like more tech or something. The best material that we have for molding is plaster cast. no question. Okay, so if you don't use plaster casts, then you are going to start seeing patients that are not going to respond as good. And maybe it's 1 or 2%. But if you have something that works 100%, why do you want to give up in 1 or 2%? And this paper is a paper in which they evaluate different materials, and plaster cast is the best molding material scientifically. So the problem also is like you say, oh, I did a tenotomy, but it didn't correct the clubfoot. Well, the tenotomy is not going to correct the clubfoot. The tenotomy is a procedure that you do at the right time when the foot is ready, and you are going to obtain a result with the tenotomy. It's not like you do the tenotomy and see what happened. So, and this is what happens sometimes. You do, and then they get swelling, and then you have a complex situation coming up, and then you do a tenotomy to see if I can get it better. Then the cast comes out of the cast, and then it's like this. And now you have a scar tissue over here, and it's so hard to stretch those feet. And the best is actually to wait for a month or two, let it cool down, and then you start all over again. But the tenotomy is not going to do anything for you. You have to decide when to do it right. The same thing with the bracing. You say, well, the kid is having 2.5 years old, is having problems with the brace. Well, let's put in an AFO because it's easier, because it's only one side or something, and then 6 months later, come back and the foot is like this. It's not going to be working. That's not the solution. So when you look at the literature, and this is a paper published, which is a systematic review of all the papers on clubfoot, what they found, it's very hard to read for some reason. In the conclusions, they say, we found that the observed clinical importance variation are the result of deviation from details regarding manipulation, casting, percutaneous tenotomy, use of the brace, and indication for relapse recognition and treatment. This is based on all the papers that have been published. Every single paper pretty much has changed something on the method. And so the variability that you see, like some papers have a 40% relapse rate. Well, they have a 40% relapse rate because you're not using the brace correctly. It's not because the feet are different in Israel from Egypt or from United States. They are all the same. And this paper is very, very important. I think this is one of the most important papers published recently. This is a study between two institutions. Nancy Miller was a fellow with Dr. Ponsetti back in the days, and Matt Dobbs was a resident also in Iowa. She works in Denver. In Denver, there are 16 orthopedic surgeons in children's. And what happened in Denver for many years is that the patient will call and say, I have clubfoot. Whoever was in clinic that day will get that patient, and he will start doing the casting. And those 16 providers manage the Ponsetti method, but they adapted, and I want to emphasize, adapted the technique to their clinics and to their practices. Okay, so some of them use soft cast, some of them use plaster, some of them use fiberglass, some of them use AFO, some of them, and then all of them were doing Ponsetti. And what happened is when you compare with a clinic, which it was Matt Dobbs, which he does Ponsetti, the number of surgeries for the group of the 16, it was 47%. 47%. Matt Dobbs, 2 out of 91. And this is including relapses. So if you adapt the method, it's not going to work. The method has 60 years of track record, and if you learn how to do properly, and you know how to do the casting well, and you follow the protocol with casting, you are going to see just very few relapses and very few cases that will need surgery. What happened in the United States, which I was telling you this morning, this is a study that is coming up, we just submitted. In the first year of life, from 1997 to 2012, 2000 is the break. You can see the number of surgeries in the first year of life, which is in the blue, it has decreased. The number of surgeries after the first year of life is exactly the same. So when people do the casting, it gets okay, and then you start the bracing, and then you start having problems with bracing, and then boom, same surgeries. This is actual data from the United States, because this database captures all the coding in all the insurance companies in a national program. And the NIH used this database to see trends on pathology. So when we look at this data, we were completely astonished. It's like, because if in 2000 people would do the Ponseti method, all the surgeries shouldn't have to happen, or very few of them. So unfortunately, in the United States still, it suggests that the people are not using the method properly and they are using something similar to Ponseti-like. In this paper from England, they used to do the clinic, the patient comes and then you do it and then you have a fracture and then an Elizar or something and then a scoliosis and then a hip and then another kid comes and then you do the casting and so forth. If you do it that way, you don't have a good process. And when they changed to having a dedicated clinic with one doctor, one nurse of physiotherapist and an orthotic person there, and they do it on Monday, and the patients come and they do it all the time, the same, with a process, their surgery rate and the recurrence rate went down dramatically. The same thing that happened with a group in Denver. So you have to think about the Ponseti method and doing the casting and the treatment as you will be doing the surgery. You have to be very precise on your technique. You have to do it in an environment that allows the kid to be relaxed, because if you are stretching tissue and the kid is crying, there's no way to stretch anything. And the more you stretch, the more he cries, the more tighter it is, the more pain, the worse it gets. So the kid has to be completely relaxed, and I think this is critical. And then you have to have a process so it's always the same. So it becomes a repetitive thing, and then your results go up dramatically. So a Clubfoot clinic is also require a facility, means a room for the casting, personnel, you need to train somebody to help you, and then you need, as we have discussed all day, the parents to get involved into the treatment. So it's very hard to do the casting by yourself. Some people, and there's actually one or two papers saying, oh, I can do it by myself. Yeah, you can do anything by yourself, but are you getting good results? And so you need your help. The parents are your anesthesiologists. Okay, they are the ones who are going to keep the babies nice and calm. And if you do it gently, the kids don't cry too much. And that is the key. Positioning of everybody is very important. The doctor has to be on the side of the foot that you are drilling. The assistant is the one rolling, and then you do the molding, and the parents just keep the babies. And if they are doing that, they are getting involved. And that is critical. It's your job to keep the kid calm. So they have to be there. And so that's part of their treatment. And that is one way to, and then you talk about bracing, blah, 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 and that's the way you get them, okay? Patient, relax, you see? Milk is great, and the older kids, bubbles, and I'm pushing here, and the kid is, completely concentrated on the bubbles, and then you can stretch much more. How you position the thumb is very critical. We will do that this afternoon, so we will pass on that. But I cannot overemphasize enough that the key for the casting is the molding. You are molding the foot. So what is the composition of a leg in a newborn baby? 85 to 90%. Okay, so you have to create a container with the shape of a foot so that water takes that shape. Okay? If you don't create a container with the shape of a foot, the foot is coming whatever the shape of the container you produce because it's 80 to 90% water. So you'd have to mold the cast in a way that resembles a normal foot. If you don't do that, the foot is going to be looking whatever the shape that you produce. And this is critical. We mentioned about, the toes. If you don't do a platform, then you get claw toes. And when you bend the knee, you have to make sure that this is straight, it's not round, and you have to go all the way up. And these are all technical issues. And finally, I think one of the main reasons why having the clinic the same day, even if it is 5 patients, like, okay, Mondays at 9 o'clock is Clubfoot clinic, and there are 5 patients, you finish those 5, and then you do whatever you need to be doing. And you have 25, then it's 25, is because the clinic becomes a support group. And there's nothing better for a family that comes with a baby, newborn, that they are concerned about the baby's not going to be walking and this and that. to see a 3-year-old walking around, and then mom gets the the iPhone thing or whatever, and he's like, oh, look at my kid. These are the pictures when he was a baby, and now he's running. And that mom is like, okay, I think it's going to be just fine. We are in the right place. The other reason for doing a Clubfoot clinic is because the parents know then that they are coming to a special place in which Clubfoot is the only pathology. So they know that their problem is going to be treated the same way that you go to the cancer center, or you go to the cardiac center, or you go to, psychologically, the parents have more faith on what you're doing is just specifically dedicated for that deformity. And it doesn't take too much. It's just same-day clinic. And just remember, the parents are part of the team. Without the parents, as you said this morning, without the bracing, don't even start the Clubfoot Ponseti, because it's going to fail. I mean, it's just the way it is. So if the parents are not part of the team, it's going to be a really painful experience for you with a 40 or 50% relapse rate and all the negativity that has and all the blaming and everything. So the key is to empower the parents to be successful. That's 90% of the Ponseti method. So follow the protocol, make them partners, encourage them, and remind them. One of the things that we did a study asking them, what do you like or you didn't like on your process? And every family said, what I like the best when I come to your clinic is that you always remind me that I'm doing great, we are doing great, and the kid is going to be fine. That's what the parents want to know. Just think about yourself if you have a kid with Clubfoot. When you want to go to the clinic is to say, you are doing great, your foot looks great, you have very, very good flexibility, keep it going because you are succeeding and the kid is wonderful and the feet are beautiful. I use those words for the kids. And then the family just go back home and they are happy as like anybody and then they keep doing the bracing. So you have to be like the coach of the football team for the national team in Israel. Okay, you have good days and bad days, you sometimes win and sometimes you don't, but if you don't give up and say, okay, everybody fire, which means, kids go to surgery. No, it's like, well, what happened? Why we didn't win this time? I mean, that's the same thing with the bracing. Why aren't you using the brace? Let's tell me. I mean, let's talk about it. And I think we as orthopedic surgeons, and I emphasize the word surgeons, are not accustomed to do that. We just think about, what do I do next? How do I fix the problem today? And the fixing the problem today is talking with the families and make sure that they go back to the bracing and so forth. So take no excuses and identify the barriers, because when you do that, you can decrease your surgery rate. And it's not just not to do surgery, it's because it's better for the patients. The less scar, the more mobility, the longer, and the best is the long-term follow-up. So if they don't need an anterior teeth transfer, it's better than they do need an anterior teeth transfer. Or the anterior teeth transfer is an okay solution and it's going to lead to good long-term results. But it's an expense. In the United States, it's about $35,000 in today's money to do one anterior teeth transfer. And and sometimes doesn't work that great. So that is, I think this is something important for you to consider. And I think the most important thing is for you to think about that this is not a low-tech technique with respect to, because it's plastered and you get dirty and everything. It's a very, very powerful technique that when you use it correctly and you master the casting technique, it's a very, very powerful technique that can help a lot to a lot of your families. So think about it, and when you go home, try to arrange your clinic in a way that is conducive to get the results that many people are getting in their clinics. So thank you.